Thank you. I'd like to thank the organizers for the invitation to speak today. And so my position that is going to be that the best induction therapy for transplant-eligible patients is combination therapy. And I think it's important to focus on the transplant-eligible because I think the goals, obviously, for our induction therapy are going to be different. And so if you think about our current toolbox for myeloma, you saw the 6-shooter, and I think this is another representation of that. All of these agents listed, the steroids, the 3 IMiDs, proteasome inhibitors, and conventional chemotherapeutics could all be used in the treatment of myeloma. Of these, probably pomalidomide and melphalan and carfilzomib also, actually, those 3 would not be used typically in an induction for a transplant-eligible patient, although we'll see some data for carfilzomib. And bendamustine, actually, there's some data even using that in terms of stem cell collection. So, but the question is, what of these 4 classes should we use? Should we use 2, 3, 4? And I would submit that we should use more than 2. And I think, again, focusing on symptomatic patients, obviously we all know that these are patients with, as opposed to high-risk smoldering, where the objective there is different. These are patients who have anemia, bone pain, renal failure, hypercalcemia, infection. And I think we're trying to reverse these quickly. I just saw a patient in clinic yesterday who was debilitated and essentially bedbound from her bone pain. And after combination triplet therapy, she's now ambulating without any problems within 3 cycles of therapy. And I think it's important to remind ourselves of that's our real goal for helping these patients to improve quickly. And there's a lot of talk also that we should be risk stratifying our patients in terms of choosing the right therapy for a given patient. And I think that's a noble effort, but I think we have a lot of work to do. If you look at the things that we could use to risk stratify patients, broadly you could divide them into the disease burden by Durisam and ISS, MRI and PET scan, extramedullary disease, plasma cell leukemia. There's host factors, obviously age, performance status, probably more important than age as we've heard today, renal function, and then most importantly, the biology of the disease, LDH, plasma cell labeling index, cytogenetics, FISH, and gene expression profiling. And I put this up here because it is the rare patient for which we have this complete panoply of information to really risk stratify that patient. At most, we might have 1 or 2 of these, and I'm not by any means proposing that every patient should have all of these, but I think if we don't do all of that, you don't necessarily know the complete risk of a given patient. And I would also like to just mention before we go forward that these are all prognostic variables. We really lack in myeloma predictive variables. So if one of these things could predict a response, that would really allow us to tailor our therapy. I don't think we're there yet, and most of these are prognostic variables. And so if you think about the history of our induction regimens, we have the doublet therapy with actually singlet, just Dex alone, followed by Thal-Dex. And the response rates are shown there, 46 to 63%. And then with the CR rate of relatively low, 3 to 8%. And these are all from 3 phase 3 studies. VAD versus VD, slightly higher response CR rate, and the overall response rate's also slightly higher. And then RD versus high-dose Dex versus low-dose Dex, similar response rates. And I'm going to emphasize that we look at after 4 cycles, because again, these are transplant-eligible patients, and I think it's important to look at a lot of the data in that context. So although I would concede that it's going to be hard to show overall survival, remembering that these are newly diagnosed patients, and the improvement in overall survival for patients, it's going to be very unlikely that an induction therapy study is going to show an overall survival benefit, given that the median survival for myeloma is now increasing to 5 to 7 years. And again, these patients, many of them who choose to go to transplant, that's obviously going to confound the responses. So if we really focus for this talk on the 4-cycle response, obviously we've all heard about the triplet RVD regimen. This is the standard schedule, Len 14 days, bortezomib 1, 4, 8, and 11, and Dex day of and after. And that's been shown to have about a 6% CR rate, 11% VGPR. And again, you see that these numbers are actually slightly lower than the published because, again, this is after 4 cycles. The overall response rate, if you look at the best response, is going to be 100%. But at 4 cycles, we have 75. And in our program, we've been using a slightly modified regimen based on the several studies that have shown that the dose intensity of bortezomib matters. And if you spread out the bortezomib instead of 1, 4, 8, and 11 to 1, 4, 11, and 18 using the 21-day Len backbone and very limited dex just the day of. We actually, in our study of 38 patients, actually had, after 4 cycles, 63% had VGPR better and a 97% response rate. And I think this is coming from the fact of the number of dose reductions that were needed. So instead of 44% of patients requiring dose reductions, 8%. Again, small retrospective study. I'm not trying to overstate anything, but I think the key, this goes back to one of the things, is the risk-benefit ratio of a given regimen. So if you can deliver triplet therapy in a safe fashion and you get good response rate, why not? And you've seen this study already by several speakers, so I'm not going to go through it extensively. But just to point out, so if 3 drugs are good, are 4 drugs even better? And the evolution study, looking at the overall response rate, we saw that for VRD, 85%, VDC, 75%. When you add Len, not really significantly different, but there was increased neutropenia. So we don't think 4 drugs is necessarily better than 3, but I think, again, when you're going to add drugs, you really need to think about the toxicity pattern. And if you're going to have overlapping toxicity patterns, such as neutropenia, probably does not make sense to keep adding drugs to the combination. And the overall response rate in this relatively smaller number, 17 patients, was 100%. And so kind of interesting. One thing that I didn't include on here because the numbers are very small is also this evolving concept of MRD. And so if you look at the rates of MRD in these 4 subgroups, it was much higher in the Len-based combinations than these. There was actually no patient who achieved MRD in VDC, very small number here at about 50 to 80%. Again, not every patient was evaluable for MRD, but suggesting that there may be additional benefit. And so when might cyclophosphamide be preferential to a imide-based combination? And so perhaps cyclophosphamide might be preferable in renal failure relative to Len, poor performance status given the venous thrombotic risk, especially in somebody who might be at risk of bleeding, an inpatient, need to initiate rapid outpatient therapy in somebody who has cord compression perhaps, intolerance obviously, washing out in that month before stem cell collection. If you think that oral therapy for some reason is not dependable, either non-compliant patient or malabsorption in somebody who might have amyloid, for example. So those are some of the reasons that you might pick a cyclophosphamide. And of course, one of the newest things that people have been talking about a lot is carfilzomib lenalidomide index, and this was published in Blood. And basically, this is a triplet regimen where carfilzomib was given either at 27 milligrams per meter squared or 36 milligrams per meter squared, with Len standard dose 25 for 21 days and dex as shown here weekly. And so very rapid drop in paraproteins. Even on day 15, you see already a significant drop. And in terms of the response after 4 cycles, you'll see here that the overall response rate was 100%, VGPR 88%, and so even CRs seeing very quickly. And this was independent of high-risk features. And what about the toxicity? Again, going back to the risk-benefit question, during the dose escalation, the DLTs, there were none seen in the low dose, some neutropenia at 27, and at 36, grade 4 pulmonary edema and dyspnea. And so as you go up on the dose, there was a slight dose increase in toxicity, as you might expect. Some of the dyspnea was attributed to hydration or methemoglobinemia in a patient who had received dapsone. I do think we need to do more work in terms of carfilzomib Len Dex. This is category 2 on NCCN guidelines for induction therapy. However, we do need to use some caution. Both studies that were reported at ASH this past year at the NIH with either smoldering or newly diagnosed myeloma had a signal of heart failure, 2 out of 20 and 1 out of 8. And so I think that is a signal that we really do need to work on in terms of figuring out who's at risk for developing that. And so again, not trying to compare across studies, but just to put the framework of all of the regimens that we've seen so far. Here's the sample size of the various studies. And what you see is the ones in red. I've included our Cornell colleagues' BIRD regimen, but I could only find response rates after 6 months, showing 95%, 97% for triplet RVD, 100% for CRD, carfilzomib, cyclophosphamide, Dex. So these are probably showing some of the highest response rate. Again, it's hard to compare across these small numbers, especially without adequate data for risk stratification. So I think this just gives us the framework, if you will, for triplet. And I think just to put that a little bit into context, the Italian group showing VTD versus TD in patients who had induction, first transplant, second transplant, consolidation. Some of the response rates in terms of CR rates that we're seeing now with just induction carfilzomib Len Dex are really impressive in the context of 63% after induction, first transplant, second transplant. So I think there's really a great signal here. Again, we're not going to see an overall survival benefit in these newly diagnosed patients who are getting a short initial difference in therapy, and the PFS was superior. And the other thing in terms of the toxicity of these regimens, very limited data. In fact, I was trying to really look to see what percent, for example, in particular had dose reductions, which I think is an important measure of how well patients tolerated this. Very limited data. Significant reductions in the 21-day RVD regimen, anywhere from 35 to 50% of the 3 drugs indicated. In our study, we only had 8% in each arm. In terms of peripheral neuropathy, as shown here, a lot of these studies, we don't even have the reported data. And I think, obviously, we do need to think about cost and quality of life, and I'll get to that in a second. So the question is, you're doing induction therapy for, say, 4 cycles, and you're collecting these cells, and then if you're going to transplant, does it matter? Do we need to be using more drugs if you're going to take somebody to transplant anyway? And actually, to that point, we have this large study going on with the Dana-Farber and IFM, and I would say that that study, which is comparing everybody is getting Len Dex and then half get randomized to early transplant, the other half continue with therapy, that study was never proposed when we were talking about Thal-Dex or Dex. I think this question is only being asked now because we do have such potent agents and we can and getting such good deep responses that we need to compare those 2 arms. But if you look at, this was a meta-analysis in terms of does the quality of response matter after high-dose transplant? And both in prospective and retrospective studies, there was an improvement in overall survival with a better response. Now, I think this data we have to take a little bit with a caveat that this is not really a fair analysis. Responding patients always do better, and really a better way of doing this would be a landmark analysis, picking a time point and comparing that. But I think at least this is some data, and I think more important than that is the question of, again, what does the quality of your response to induction therapy matter today? And so these were 2 studies, the Italian group and the French group, showing that in both studies, as clearly shown here, if you're comparing patients who got single versus double transplant, the only patients who really benefit are those who did not achieve a very good partial remission. And so the question is, does this still matter in the current era? And this is the French update. And you basically see that if you look at patients, this is VAD followed by DCEP, melphalan, and then first transplant or second transplant, and the other side has a bortezomib-based induction regimen. And you can see that the PFS, both after induction, transplant, and post-transplant, all of these are actually superior. Even if you're using bortezomib-based regimen, if you have a better response rate, the PFS was improved. And so I would say that if you have a better induction regimen and you're getting a better response, you're going to get a better stem cell collection, and you've essentially eliminated the need for a second transplant. And especially in this cost-conscious environment, a second transplant is not an inexpensive thing. Obviously, the hospitalization, the morbidity, and the cost. And so if our novel therapies are able to avoid a second transplant, I think that's a pretty good outcome. And then basically, what about new drugs? And I've added in here all the other drugs, many of the other drugs that were under investigation. These 2 drugs being oral, so potentially oral combination regimens. We do have epigenetic modulators. The Emory group has presented so-called R2V2, which is lenalidomide, dexamethasone, and bortezomib with the addition of vernistat. Preliminary results show very rapid and deep responses, adding signal transduction inhibitors, cell cycle inhibitors, and this is going to be an interesting class. Again, going back to avoiding overlapping toxicity, the monoclonals have not shown significant myelosuppression, and both elotuzumab and perhaps daratumumab would be very interesting to combine in an upfront setting and with our currently available drugs, and obviously our bone-modifying agents. So to summarize, I think we're talking about symptomatic myeloma patients, and they would benefit from both rapid and deep resolution of their symptoms. We know that multi-drug regimens are associated with higher response rates. If you don't have overlapping toxicity of the drugs, combination regimens are very well tolerated. induction therapy is not continued until disease progression. And we know from many studies that retreatment is very feasible as long as you're not treating to progression, whether it's bortezomib, Len, pick your agent. If they've not progressed on it, you can certainly retreat them post-transplant. Myeloma is very heterogeneous, and to date, our so-called risk-stratified algorithms are not based on prospective phase 3 studies. And I don't think we're yet at the point with non-Hodgkin's lymphoma where your therapy differs dramatically whether you have follicular, diffuse large B-cell lymphoma, or Burkitt's. I think we're still trying to determine that, as we really don't have good predictive models. And our risk definitions keep evolving. 13q was what we considered high risk. Now we used to think translocation 414, which we think can be overcome with proteasome inhibitors, chromosome 1q, and so on and so forth. And obviously, risk always needs to be considered in the context of therapy. And so I would propose that the improved depth of response with combination therapy pre-transplant improves the likelihood of a good stem cell harvest, decreases the likelihood of a second transplant, and may increase PFS. Thank you.